Okay, welcome back everyone to another episode of Med Chat Monday Healthcare Specialty Series, where we dive into the different healthcare specialties that exist out there to give you a better perspective of the particular profession you might want to pursue later in life. So please subscribe to the channel if you are interested in the topics that Med Chat Monday is covering, because we're going to have so many interesting speakers. But today, we are going to have a really interesting speaker. Dr. Yates is a pediatric hematologist who's going to talk to us about her journey to become a doctor, how she became a pediatric hematologist, and some of the exciting things she's doing with sickle cell disease. So Dr. Yates, welcome to the show. We're so excited to have you. Thank you for taking time out of your busy schedule to inspire us about becoming a hematologist focused in the pediatric space.
Oh, I'm so excited to be here. It's always fun to talk about journeys and how you get to where you are, because it's certainly not the path I thought I was starting when I started it many years ago. It wasn't exactly what I envisioned I would be doing today.
Well, it never is. We never know where we're going to end up, okay? But we want to get perspective. So first off, why medicine? Why did you pursue a career in medicine?
I think I'm one of those classic people, wanted to take care of people. One of those young kids who, took care of their dolls and their wagons, Dr. Kit kind of people. But what really solidified it for me was when I was in middle school, a girl who was 2 or 3 grades behind me was diagnosed with Wilms tumor, a cancer of the kidneys. And she was
classic textbook USMLE.
Oh yes. 3-year-old in the bathtub. Yes. These are classic things. And so, she rode the same school bus as me. And so I kind of knew her pretty well, and she did well for a while, but she relapsed, after being in remission. And I didn't understand what that meant. I thought she was cured, and that's like at that point where I didn't understand the differences between that. And she ultimately succumbed and died of her disease. And it just left these puzzling questions in my mind about well, how did it come back? And, it was in her belly. And I remember she got hurt on the playground right beforehand. And I had well, did that have anything to do with it? Right? Did it set off her cancer cells? And all these questions in my mind. And a year or 2 after her, a middle school boy died of leukemia, and so it was just these puzzling questions that kind of just set it all off in motion. I was like, I have to know more. I want to understand more about what's happening. What happens? Why doesn't the treatment work, or why don't kids survive this? And so that was kind of my start, was in middle school, where I really, it's like, this is definitely what I want to do. This is where I want to go.
You know what I think is amazing? I think what's amazing is that you were so young when you were exposed to some of the Wilms tumor, rare, in the sense that you don't see it
in
the public all the time, but yet you were exposed to it at a very young age. So that probably gave you a trajectory that you were going to head towards at least a field in medicine or in healthcare.
Right. Yeah, for sure. I still picture her today. She was my, my personal statement for medical school, for sure, of what put me on my path to go into healthcare. I just had to know more, understand more, know more about the body and how it worked and how you get cancer cells and how do they change, right? How does your kidney go from being a normal organ to having these cells that go out of control? What happens? I wanted to understand that better.
So when you got to medical school your first year, did you know that you were going to be doing something with oncology, hematology? Did you know you were going to be focused on pediatrics because you had those earlier experiences where you saw young kids affected by leukemia, Wilms tumor? Was that the foundation for why you eventually chose the pathway for pediatric hematology?
Yeah, so I'm one of those dorky people who said on day one I was going to be a pediatric hematology oncologist, and I never looked back. So pediatrics for sure. Every job I've ever had in my life has been around kids. High school student working at a Discovery Zone, throwing birthday parties for 5-year-olds. nannying, all of that. So pediatrics was never, ever, it was never like, is it peds or adult hematology? Ever, 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 never in question, never in question. And so, yeah, I had this kind of clear vision of that's what I wanted to pursue. And so I just never looked back. It just was the path I wanted to take. And, of course, everyone was like, you'll change your mind. Just wait. You'll find something else that interests you. And it just never did. And then fourth year of medical school, I worked with the local pediatric hematologist, oncologist at the medical school, which is actually in my hometown. And so I just loved it. Like, as soon as I was there, I was like, I'm home. This is what I want to do. Like,
how would you define pediatric hematology?
So, just to point it out, because it's different in pediatrics and adults. When we say pediatric hematology, we mean non-malignant heme disorders. In the adult world, they mean both. So when I say hematology, I mean non-malignant disorders. And so all things with the blood that don't have to do with cancer, basically, in my world. But specifically for me, anything to do with the red cell just makes me excited and lovely. And so, but that's not, at that point in my life, I still thought I would come home to my relatively small city where I grew up and be a general peds hem-onc doctor, kind of the all-encompassing, do-it-all peds, heme, and onc, in a relatively small city, and kind of be the one-stop shop where you did everything together. I didn't have grand aspirations to be a special sub-specialist as I am today. And so that's where things got a little off track.
Okay, so let's go through the journey. So you went through medical school. You say you're going to do pediatric hematology. What were those first 2 years like? Is there anything special that you would have done differently knowing that you were going to go into that field?
I don't know. I don't think so.
Well, was it important to do research?
So, I think it is. I think it's important to understand that on a level. Even though that's not a huge part of my life now, pediatric hem-onc has this very special thing that, like, one of the things that sets us apart as a field is the amount of research that's done, and the very strategic way research has been done in peds hem-onc is that we've been very focused. We've come together as groups of people where we do it all the same, and we keep looking for the best way to do it. Adult oncology is starting to take notice because, you could go to an adult oncologist and get a different treatment plan for your cancer from multiple different doctors. If you have a kid with cancer, you go across this country, you're likely to get the very same treatment plan from every single doctor. It's because we do everything very similarly to try to, in an effort to find the best treatment plan for every single kid. And so it's a part of the process of finding the best treatment with the least amount of side effects for kids, because when you treat a kid for cancer, it's not just about curing the cancer, but their decades of life that they have afterwards. And so you have to think about that when you treat them. So you have to consider that when you do your research, right? You want to cure them, but you want to do it with as least toxicity as possible. And the same thing happens in hematology, because so many of our conditions are chronic, lifelong. You're not going to cure it, but you're going to live with it for the rest of your life. You want to find treatments that will work, but without altering their lives too dramatically.
So if I may ask, so you would advise a medical student during their years of medical school to spend time doing either bench work or clinical research to improve their CV, but also increase their exposure to the cutting edge research that's going out that's out there, so that you can take care of your patients when you're out there practicing.
Yeah. And I would say that even if you don't know what you want to do, like you don't know for hem-onc per se, it doesn't really matter what your research is in at that point in your career, right? It's the fact that you took the time to invest in a research to understand what that means and how people go about asking these scientific questions and developing hypotheses and proceeding through them. Because I review our fellow applicants who want to become peds hem-onc doctors. It's more about that. Did you find time to look into that, because it's such a huge component of what peds hem-onc is? Did you find time to fit that into your training through the years so that shows dedication to what is part of our jobs, and that you understand the science? Did you understand the questioning and the thought process behind so many of our clinical research trials? Start with those kind of small questions, often start in a lab and develop over time to get all the way to the clinic. And it just shows a lot of dedication to our field, but it doesn't have to. We have lots of people who start in basic science labs who have absolutely nothing to do with PT-Monk, but then over time, as they figure out that's their field, then it slowly transitions over and their peds residency or, and things like that. But it's a great place to start, whatever interests you at the time.
Of course, but as you stressed, recognizing that the field you're in requires that you have a strong connection with research.
Yeah,
and
it does.
It has a lot to do with the community of doctors and scientists that are part of taking care of these very sick kids who have very severe diseases, and it requires that kind of commitment to the sciences.
Absolutely.
So take us through your third and fourth year. Did you have a mentor? Did you do certain types of rotations to expose you to the field? And give you a little more confidence, but also give you that opportunity to pick, ultimately the residency programs that you wanted to go to?
So I made sure that I did pediatrics early. I wanted to make sure that I got on the floors early and that people were aware that I was interested. But then I did do a fourth year rotation in PT-Monk, both at my own program, but then I did an away rotation at actually what ended up being my fellowship program because I was very interested in it. So I did a away rotation as a fourth year medical student at St. Jude Children's Research Hospital, which actually my medical school was affiliated with. We ran an affiliate clinic at our medical school. And so that was a huge benefit to go somewhere so prestigious and to be exposed to that sort of environment where they write their own clinical trials and to read. I would just read the background sections of these clinical trials. It's amazing how they would go through the history of how they came to this particular trial, of all the trial and error that they had before that. And it was fascinating to me. And then at home, my home med school, because I was interested, the PT-Monk doctor would ask me to come do procedures with him. Let's do this bone marrow aspirate and biopsy. Let's do this lumbar puncture with intrathecal chemo, these opportunities. No one else said they wanted to do it. He's like, well, come on, let's do it. So then when I had letter writers, he was like, oh, she can do all these procedures, and it was really grand to have somebody who could say that about me. But it was only because I gave this knowledge that I was interested in this field and I would love to learn about this field. And he just took advantage of that opportunity and that we weren't a very large medical school and he could give me that opportunity. It was fantastic.
How important is it to get a heme-onc or heme pediatric exposure early on? Or could you just do pediatric rotations and then later on when you're in your residency years say, you know what, I want to do hematology or I want to do oncology? Is it important in medical school to get that early exposure?
I don't know that in medical school it's as important. I just had a good opportunity. So no, I don't think it's as important, doing a good sub-I or potentially going away to do a good, junior internship or sub-I, depending on what your school calls it. It may be at a program you're really interested in so that you get a really strong residency program where you want to go is probably more important. Because there's usually time in residency to really focus on hem-onc if that's what you're really interested in. I just had a program where it was a pretty simple process to do that, and I knew where I wanted to go because of the exposure I had. Growing up in a town where St. Jude was such a common household name. And so I think that made it really simple, and that the doctor had such a close connection that he could put me in connection with them. And so I think it was just kind of a perfect example. But I don't necessarily go back and when I look at fellowship applications, I'm not I kind of breeze through your med school transcript, make sure you've had all the usual stuff, but I'm not nitpicking about that because it's really more about where did you, do your residency and are you doing well in that and have you put forth the effort again during that time to focus on it and spend time in it and do research and things like that.
Dr. Yates, if I may ask, do you have to take a pediatric pathway to do hematology focus in pediatrics? Can you do family medicine and then go the hematology route, or you have to go through pediatrics?
Pediatrics first. Yeah, so you either do pediatrics and then do specialty training in pediatric hematology oncology, or you go in internal medicine and then do onc training afterwards to be an adult counterpart. So yeah, you have to pick one of the two kind of general categories first, and then you specialize after that. So you have to choose pediatrics. You have to decide, although it is becoming more common for people to choose a med peds pathway, so do the combined residency program, internal medicine and pediatrics, and then do fellowships in both peds, hemonc, and adult hemonc, where they can take care of particularly patients who are in transitional ages, which is really amazing.
Okay, so take us through those residency years. What were they like? Were they intense? I know that your focus was on hematology, so is there anything that you did particularly different than a typical pediatric resident?
So, I mean, I think anybody who tells you residency is not tough is telling you a story. It was tough. I was the first residency class of the first rendition of work hour restrictions of the first 80-hour work week.
And they didn't figure that out yet. You were the guinea pig.
30-hour in a row. That was the first rendition of it. But I still know pretty much everyone in my first year class for sure. We're close-knit people, like family pretty much, because they are the only people you saw. It was a good group. Things I did were, we didn't do our hemonc rotations until our second year of residency at my program. And at that time, hemonc match was early. It was in the first half of the second year of residency. Thank goodness it's moved since then. And so I made sure to tell the program, I need you to schedule these months in the first part of the year, because I wanted someone in the hemonc group to be able to write me a letter for fellowship applications. And the only way I was going to be able to do that was to do that rotation early. And so that was definitely something I needed to do as far as thinking ahead about my calendar and my rotation schedule, so that I could work with someone at our program who could then speak about my knowledge and skills and how I worked on the wards there and things like that. So you have to think about that. Thankfully now,
letters of recommendation are very important.
They are. And you really want, when you ask somebody to write a letter, you want someone who really can speak to you personally. The more close interactions they have with you and can really speak to the length of time they've known you, how close they've actually known you, like I've known them for, this many years, and we worked together, like how intimately they've worked, like we were on the wards together, taking care of these patients. The more you have that, the more it means something that you got a letter from them, other than, your division chief heard about you and people said these great things about you, is not the same as this person saying, I worked right alongside this resident, and when we worked together, I thought they were amazing. It means something different. A department head is just going to kind of summarize what everybody said about you, and that's great if everybody thought you were great, but having somebody who's a letter writer who can really speak to how good of a resident you were and how you spoke to families and what they thought, how well you presented on rounds, that's what you really want out of someone, to write you a letter. And so the best way to do that is to work with people. And especially if you have the ability to go away on a rotation, maybe at a place you really want to work at, that's a potential that maybe if you don't look as strong on paper, I will admit that I was not, if you look at, on my med school rotations and things like that, I'm not the strongest candidate. And so I made sure I rotated at the program I wanted to go to so they could see me and how I work and what my work ethic was like, and my medical knowledge that maybe on a test doesn't come off as well as it is in real life, so that they could see me in real life and what I'm like and what skill set I actually have.
So these rotations are very important. These away rotations.
Yeah, I think so. For me, I think because it gives them exposure to you, and then when you come to interview, right, they know you as opposed to these other group of people, right, who are coming in for one day, a day and a half of interviewing, which they just see on paper in this limited amount of time that they see them, right? So they have more time to know what you're like and how you work, and if you would maybe merge well in their other teams and things like that. So I think it gives them a good idea of how you might function in their team. And so I think that, in my opinion, they're very helpful. If you have some ideas, about where you might want to go. And maybe you don't, and that's okay. But for me,
if I may ask, is it important to do research during your residency?
At this point, yes. It's almost, if you want to top
it's so competitive now to get hematology.
Yeah, because you pretty much at this point in PT-Monk, if you're not doing some sort, now it can be as simple as doing clinical chart reviews with somebody, right? It doesn't have to be this very robust, start from scratch, research in a lab. No one's expecting a resident to be able to figure that out in the middle of their research, in the middle of their very busy intern year. But you have to show some effort that this is what you really want to do, and you understand that research is part of it. And when it's as competitive as it is right now, it's an easy way to kind of say, like, well, this person hasn't really found any way to make that happen, and this person has. And so in this day and age, I think you have to put forth some effort. But clinical research, like something happens when you're on the floor and it fascinates you, well, ask your attending, right? I saw this happen. Does that happen often? Or do you think there's a question here I could ask?
It could be a case report that they could write up.
Right. These sort of things count and are very crucial to our field and further the field when you describe unusual presentations of patients and things like that. Those are important. And so those sort of things help us see that you're interested in the academic side of what we do.
So now you get into your fellowship. What does the fellowship look like? Is it 2 years? Is it 1 year? Is it 3 years? How intense is it?
So like most pediatric subspecialties, it's 3 years total, and it's peds, heme, and onc. So all of us train in both fields. And so most programs are about the same: 1 year clinical work and then 2 years of research. And so I spent all my clinical time in the first year, which was intense but good. And so you spend different times and it depends on which institution you're at. I had pretty split time between hematology and oncology where I was, and a little time on bone marrow transplantation, and then both in inpatient and outpatient time. And then you go into your research years and you spend at least 2 years in research, because to be board eligible to get your board certification, you have to have a research product at the end of your fellowship. And so,
sometimes it takes longer.
Oh yeah, it's not uncommon to take a fourth year of fellowship. And so
that's why we're doing this interview, so people get perspective that, there's commitment. I think you mentioned that at the beginning of this, that this is a long road, and you have to be committed to the end result, which is, eventually being able to really truly impact someone's life in a real way.
Yeah, and so so what you do for research there can vary a lot. So I did clinical research as a fellow. So I didn't go to a lab. That's not what interests me.
You could choose lab. As an option.
The fellow I shared my office with as a upper level fellow worked in a lab, did translational research in a lab with the same mentor. So he mentored her in the lab and mentored me in clinical research. And so it was just a choice. There are definitely some PT-Monk programs, and they're very upfront about it, that it will be the expectation that you do go to a lab to do basic or translational research. And that's their program. So that's important
to know. May ask, so you get to the end of your training. Mm-hmm. You never get to the end of your training because you're always learning. But you get to the end of your fellowship. What are the options? Do you work for the hospital? Can you start your own private practice? Do you go into pharmaceuticals? I mean, what are the career options for someone who finishes their extensive training?
So I would say the majority of PT-Monk is in academic medicine, probably 75%, or I don't know what the percentage are, but the large majority of PT-Monk is in academic medicine, and academic institutions where you are in a traditional academic track of assistant, associate, professor type tracks, where you work for a department of pediatrics. There are some private practice where you work for either a hospital or a private practice in the United States. Those are not as frequent as, say, an adult hemonc. That would probably be the predominant model. And then it is becoming more common to have industry. It is rare to be able to get an industry straight out of fellowship. Most industry jobs want you to have at least 5 years of clinical work before they're willing to take you into industry. So most places, although it's becoming more common, it's not as common straight across into that. So probably mostly academia and some private practice. Like a guy who graduated a year behind me, like by second year, he had signed his contract with this private practice that he wanted to go to because he lived in Minnesota and that's where he wanted to go back home. And so he was ready. He was like, this is where I want to go. Let's go. And so,
if I may ask, what is a typical day for you now? What type of patients are you seeing on a typical day?
So I'm really lucky. So I'm in a very large center, so I get to be pretty specific about what I see in my clinic. So in my clinic, pretty much 90% or more of what I see in my clinic have to do with hemoglobin disorders. So sickle cell disease and thalassemia being the vast majority of my patients have those diseases, and then other red cell disorders. So spherocytosis and those sort of things. I see a little smattering of other things like different types of like low platelet counts and low white counts that kind of all of us kind of work up. But really the red cell disorders are kind of the heartbeat of my clinic. And when I'm on the floor in the hospital, any type of primary hematologic disorder, I take care of all of those sort of patients. So any sort of hematologic issue known to man.
So there's a lot of variety in your day.
Oh my gosh, yes. And one of the things I really like about being in hematology in particular is that almost every clinic day I have a new patient where I've gotten a referral from a general pediatrician or another subspecialist where they have a question and they want me to work through that puzzle and answer it. And I love that aspect of hematology. And sometimes it's not a hard question and sometimes it's a really weird question, especially because I work in such a large center. I love that part of constantly going through a consult and constantly going through a question of what's going on with this patient and why do these labs look like this, or, and that's not true always in every, like oncology, that doesn't happen as much, because patients come in often very ill, unfortunately, through an emergency room or things like that. But in my clinic, I get to see a lot of new patients, which is a lot of fun.
What are you most excited about in terms of where the field is going?
Oh, that's hard. Well, in my field, the fact that we're getting treatment options, which is something that didn't exist when I decided to focus my career in sickle cell disease. When I left fellowship in 2010, we had one treatment option basically.
And that's only 9 years ago.
Yeah. We had one treatment option.
Amazing.
For every patient, and they don't all respond the same or at all.
Hydroxyurea?
Yes. And now we are getting treatment options. Like we just had another drug approved by the FDA in the last year or so. And now we have other ones coming to market who are getting more clinical research trials. And now we're getting pretty close to more clinical trials for gene therapy. And and it's just exciting to think about this whole world of options, like to be able to talk to families about, well, these are the different choices. Let's come up with the best choice for you and your family. Like,
it's a conversation you couldn't have 10 years ago.
No, it's just amazing because these drugs work differently and some might be a better choice for this family versus this family. Also, a lot of the newer medications are being studied in all types of sickle cell disease, not just the severe types of sickle cell disease, which they haven't been in the past. And so maybe the children with the more moderate forms of sickle cell disease will actually have treatment options as well. So it's exciting, like just options, like, because those parents ask for treatments as well. And I'm like, yeah, no, I'm sorry. I don't have anything.
It's a very exciting time to be in the field that you're in.
Yes.
I'm curious though, what's tough about the field?
So I meet my patients when they're 4 to 6 weeks old because they get identified on their newborn screen, on their blood test when they're in the hospital, when they're born. And no matter how many times I do it, there is nothing easy about telling a set of parents that their brand new, beautiful baby has a horrible chronic disease, right? And it never gets easy. Like it's, for some people it says, oh, it's no big deal. People in the United States have that, but it's not. It's just not. That there's not, that their baby looks beautiful and it's perfect. And a lot of families don't realize this was even a possibility for them because of the different types of sickle cell disease. There are a lot of types. People don't know that. And to, give them this devastating news just after they've celebrated this amazing joy in their life, it's really hard, and just the amount of discrimination my patients receive because they have a lot of pain. And in this world of the opioid crisis, which is real, is hard. They have horrific pain. If you ever talk to a patient who has sickle cell disease and ask them to describe their pain, it's things that the rest of us can't imagine, bone crushing pain, like pieces of glass in your blood type pain. And yet, because of the other issues with pain medicines in this world, they get discriminated against when they also want pain medicines for a real reason. And it's frustrating. It makes me want to bang my head against the wall. And so we just continue to advocate for them. And, say, this is real. They have you can't see it on the outside, but they have blood cells that don't work right. And they just cause terrible, horrifying pain that the rest of us can't imagine. And so those are, I think, the two things that just make me so frustrated and sad for my families, that they have to kind of deal with this. But I see a tide turning. I see the advocacy efforts starting to kind of come together and be more joined than they have always been there, but just kind of a little here and a little, and I just start to see this kind of swelling, this kind of coming together. And I think it's coming, where this tide is, people are coming together. Jordan Sparks just took up the torch for sickle cell disease and to be the spokesperson for this condition, I think, which is something people needed, kind of this light, this person to kind of lead the brigade. And I think people are going to know what this disease is, and that it's out there.
And there's going to be doctors who are going to be inspired to go into pediatric hematology because of the breakthroughs.
Yeah.
Before it was futile, meaning there was only one treatment, or maybe there was two treatments. But now with the breakthroughs in gene therapy, it's a more exciting field, I should say. I think it's always been exciting, but it's even more exciting now.
Yeah, because we have that as an option, but then we got to make it a good treatment with less toxic, we got to fine tune it. And that's what's going to be exciting, is becomes a reality. That's what I'm looking for.
Dr. Yates, what would you say to a medical student if you wanted to inspire them to go into the field of pediatric hematology?
Mm-hmm. I just think about what I went into and why I changed kind of my path from kind of more maybe an oncology focused field into hematology. Is this I wanted to change the world for patients, and the world of hematology, these patients with these chronic blood disorders, they're still waiting for us to change their world, to change their chronic blood diseases, to find cures for them, to find treatment options for them. And this is this wide open world where you can do that, but there's not nearly enough of us to do it, and lots of patients who could use our help. And it's a wide open world. If you want to get into medicine and you want to change the world, we got a big world for people to change, and Pete's hematology for sure.
Dr. Yates, we go into medicine to make an impact on an individual's lives. One person. We can impact one person and change their lives for the better. We've made a difference, and you're doing that every day. So I want to thank you for inspiring the listeners, future medical students, future doctors, or if you're a nurse, or if you're a PA, or a nurse practitioner. This was an inspirational interview, and I hope it inspires future doctors to consider the field of pediatric hematology. So thank you so much for taking time out of your busy schedule.
Happy to do so.